Welcome back to the deep dive. Today, we are doing something completely different. We're dropping our usual format and stepping right into a simulation.
That's right.
I want you to really shift your mindset right now. You're not just a listener on your commute or, at the gym.
No.
You are an MD anesthesiology student.
And the setting is very specific. You can almost feel it. The air conditioning is humming, the lights are those harsh fluorescent ones, and you're sitting on a slightly uncomfortable wooden chair.
Right. Across from a table covered in that green felt.
Exactly. And you're facing your senior faculty. That's us.
Yeah.
And you are deep in prep mode for the Gujarat University MD exams.
This is high stakes. We are simulating a prep session for what I think we can call the beast of the ICU, mechanical ventilation.
Oh, absolutely.
Specifically, we're hitting the core stuff: modes, classification, and clinical use. And this isn't just about what you do at the bedside.
No, not at all. This is about how you structure a 20-mark theory answer, and maybe even more critically, how you survive the viva voce without that examiner starting to doubt you.
Why is this topic such a favorite for examiners?
It's the ultimate filter. It really is. It tests your physics, it tests your physiology, and your clinical judgment all in one go.
All at once.
If you fumble the basic concepts here, the examiner, they're going to assume you're unsafe in the ICU. It's that simple. So our mission today is to take this stack of standard texts, your ICU protocols, Marino, Miller, and just distill them into the exact narrative you need to deliver.
Okay, let's start at the absolute beginning, the framing. You're sitting there, the examiner looks over their glasses and asks, "Doctor, define mechanical ventilation." Feels like such a simple question, but it's a trap, isn't it?
It is a trap. You can't just say it helps the patient breathe. That's not an MD-level answer.
What do you say?
You need precise textbook language. Straight from the sources, the definition you give is, mechanical ventilation is a means to support or replace the patient's breathing function. But you have to immediately follow that up.
With what?
With the single most important concept in critical care: it does not cure disease.
Ah, that's the key distinction. It's a bridge. It's not the destination.
Exactly. It's a bridge. It buys time. That's all it does. It allows the body to recover, or for the antibiotics to finally kick in, or for a tired heart to rest, all while we maintain gas exchange. It is supportive, never curative.
Okay, so you've laid that foundation. You sound confident. Now you need to outline the goals. In a written exam, you can't just list survival. How do we structure this to look like a senior resident's answer?
You divide and conquer. It makes the answer look organized. Split the goals into physiological objectives and clinical objectives.
Okay, so let's start with physiological.
Physiologically, think of 3 pillars. 1, support gas exchange. That's a 2-part thing. Arterial oxygenation, getting O2 in, and alveolar ventilation, getting CO2 out.
Oxygen in, CO2 out. Got it.
Pillar 2, increased lung volume. We're talking about preventing atelectasis, those collapsed alveoli, and maintaining the functional residual capacity, the FRC.
And the third one?
Produce the work of breathing. Honestly, this is often the primary reason we intubate in the first place, to stop the patient from just completely exhausting their respiratory muscles and crashing.
And then the clinical objectives, do they just mirror these?
Pretty much. They're the clinical outcomes of the physiological goals, so you'd say. Reverse hypoxemia, reverse respiratory acidosis, prevent or treat lung collapse or atelectasis, and then the crucial one that students often forget.
What's that?
Reduce myocardial oxygen consumption. Think about it. When the diaphragm and accessory muscles are working overtime, they are stealing blood flow and oxygen from the heart. By taking over the work of breathing, we unload the heart. It's a huge deal in a patient with cardiac issues.
That's a great point. Okay, let's move to the exam list of indications. The examiner asks, when do you put a patient on a ventilator? You need a list you can rattle off.
And you need to sound confident doing it. First, the absolute no questions asked indication: apnea or respiratory arrest. If they're not breathing, you breathe for them. It's that basic.
Okay, number 1, apnea.
Second, acute respiratory failure. And you should immediately classify it. Say, this includes both type 1, which is hypoxic, and type 2, which is hypercapnic. Shows you know the physiology.
Nice. What's next?
Third is impending respiratory failure. This is where your clinical judgment comes in. The patient isn't in full failure yet, but they're getting there. They're tachypneic, they're sweating, using every accessory muscle they have. They're on the brink.
You intervene before they crash.
Precisely. Fourth, severe hypoxia. The classic definition is a PaO2 less than 60 millimeters of mercury, despite giving them high-flow supplemental oxygen.
And finally?
Finally, the prophylactic indications. This is a bit more nuanced. Think of your post-op neurosurgical patient with high intracranial pressure. Their lungs might be fine,
Right.
but we ventilate them to very strictly control their CO2 levels because high CO2 causes cerebral vasodilation and makes brain swelling worse. Or a major trauma patient in shock to reduce metabolic demand.
Okay, so that brings us back to why this topic is so high yield.
Right.
Why do they obsess over the modes?
Because understanding the modes means you have to understand the engine under the hood. It's not just about turning knobs on a machine. And this brings us right to the absolute core concepts. And it all starts with one fundamental equation.
Ah, the equation of motion. This looks like something from a physics textbook, but it dictates everything we do in the ICU.
It absolutely does. It's Pmus plus Pvent, elasticity times volume, plus resistance times flow.
Okay, break that down for me. What does that actually mean at 3 a.m. with a crashing patient?
It's simpler than it looks. The pressure needed to push gas into the lungs has to come from somewhere. It comes from either the patient's muscles, that's Pmus, or the ventilator.
We're both.
Or both, exactly. And that combined pressure has to fight against two opposing forces in the lungs. First, elasticity, which is just how stiff the lung is. A very stiff lung, like an ARDS, has high elasticity. That's related to volume.
And the second force.
Resistance. How narrow are the airways? Is there bronchospasm? Is the tube kinked? That's related to flow.
So, on the right side of the equation, you have the lungs properties, stiffness and narrowness, basically.
Yeah.
And on the left, you have the forces pushing against them.
Correct. And here is the secret sauce for the exam, the thing you have to understand. The ventilator cannot control everything. The equation forces a trade-off.
A trade-off.
Yes. This leads directly to the big two control variables that define almost every mode. You can choose to control the volume part of the equation, or you can choose to control the pressure part. But you can't control both at the same time.
Why not?
Well, think about it. If you choose volume control, you are telling the machine, deliver this exact volume and this exact flow. The machine does it. But because the equation must balance, pressure becomes the dependent variable.
Meaning it will just go to whatever level it needs to.
Exactly. If the lung gets stiffer, the pressure will go up to deliver that set volume. Conversely, if you choose pressure control, you tell the machine, apply this much airway pressure. The machine does. But now...
Now the volume is the variable.
Precisely. If the lung gets stiffer, that same pressure will now deliver a smaller volume. Understanding that one trade-off is the difference between passing and failing this topic.
Okay, that's a huge concept. Before we get into the actual modes that use these controls, let's dissect the breath cycle. The books talk about 3 phases: trigger, limit, and cycle. These terms can get a bit jumbled.
They can, but think of it as the life story of a single mechanical breath. It has a beginning, a middle, and an end.
So the trigger is the beginning.
The trigger is the start button, what initiates the breath. Is it the machine's internal timer going off? That's a time-triggered breath. Or is it the patient making a little effort, creating a drop in pressure or a change in flow? That's a patient-triggered breath.
Okay, so that's what starts it. What about the limit, the middle part?
The limit is like a governor on an engine. It's the variable that we sustain or cap during the inspiration phase. For example, in a pressure-controlled mode, the pressure is limited to, say, 20 centimeters of water.
But hitting the limit doesn't end the breath.
No, that's a common point of confusion. Hitting the limit just caps the intensity. The breath continues until the cycle variable is met.
Which is the end, the stop button.
The stop button, exactly. What tells the machine to stop pushing air in and let the patient exhale? Is it because a set volume has been delivered, then it's volume cycled? Is it because a set amount of time has passed, then it's time cycled? Or in some modes, is it because the patient's inspiratory flow has dropped to a certain level? That would be flow cycled.
Trigger, limit, cycle, start, sustain, stop. And one last basic concept: mandatory versus spontaneous.
This one's easy. A mandatory breath is one where the machine is the boss. It's either started by the machine or ended by the machine, or both.
And spontaneous.
The patient is the boss. A spontaneous breath is started by the patient and ended by the patient. The machine might help out, but the patient is in the driver's seat for timing.
Okay, we have the building blocks, the equation, the control variables, the phases of a breath. Now, let's build the actual answer for that 20-mark question. Classify ventilation modes. How do you organize this on paper so you don't just end up with a messy list?
You need a framework. Do not just list them alphabetically. That looks amateur. First, you classify them based on the control variable.
The big two.
The big two. Is it volume controlled or pressure controlled? You can also mention dual control, but keep it simple to start.
Okay, control variable first. Then what?
Then you classify based on the breath delivery pattern. And here you use a three-part system, CMV, or continuous mandatory ventilation. This means every single breath is a machine-controlled breath.
No spontaneous breaths at all.
None. Then you have IMV, or intermittent mandatory ventilation. This is a mix of machine breaths and spontaneous patient breaths.
And the third one?
CSV, or continuous spontaneous ventilation. In these modes, every breath is a spontaneous breath started and ended by the patient. The machine just provides support, like with PSV or CPAP.
So, control, then delivery pattern. That's a solid structure.
It is. Then you can add a small note about conventional versus advanced modes, just to show you're aware of things like APRV, but for the main body of the answer, you stick to the conventional ones.
All right, let's dive deep into the specific modes then. We have to start with the classic workhorse, volume-controlled ventilation, or VCV.
Right. With VCV, the principle is simple. What you set is what you get. You, the clinician, set a specific tidal volume, let's say 480 milliliters. You set a respiratory rate, say 15. You set an inspiratory flow rate.
And the machine just delivers that.
It delivers that exact volume no matter what. The flow pattern is usually constant, which looks like a square wave on the ventilator screen. That's a key feature to mention.
And the cycling mechanism, how does it stop?
It's volume cycled. The breath ends as soon as that target 480 milliliter has been delivered into the circuit.
The advantage seems pretty obvious. You guarantee the patient's minute ventilation. You know exactly how much CO2 removal you're getting.
Yes, that's its strength. Stability. But you have to remember the equation of motion. If you fixed the volume, what becomes the variable?
Pressure.
Pressure. So if your patient bites on the tube or gets a big mucus plug or their lung suddenly gets stiff from ARDS, the pressure required to force that 480 milliliters in is going to shoot up.
And that's the big disadvantage.
That's the huge disadvantage, high peak pressures.
Yeah.
This puts the patient at risk for barotrauma, literally, pressure injury. You can pop a lung, cause a pneumothorax. So in VCV, your eyes are constantly glued to that peak pressure alarm.
Okay, so let's flip the coin. Let's talk about the other side. Pressure-controlled ventilation, or PCV.
In PCV, you're setting the other side of that trade-off. You set a target inspiratory pressure, say 20 centimeters of water, and you set an inspiratory time, maybe 1 second.
And what does the machine do?
The machine pressurizes the airway circuit to 20 and holds it there for exactly 1 second. And a crucial point to mention in the exam, the flow pattern is completely different.
Not the square wave.
Not the square wave. It's a decelerating ramp. Gas rushes in really fast at the beginning to hit that pressure target, and then the flow naturally tapers off as the lung fills up.
And the cycling mechanism is time.
It's time cycled. The breath ends when the set inspiratory time, that 1 second is up. Simple as that.
So the big advantage here is safety. You're controlling the pressure.
Exactly. You are directly limiting the peak airway pressure, so your risk of barotrauma is much, much lower. Plus, a lot of physiologists argue that decelerating flow pattern is better for gas distribution in 6 stiff lungs, so you might get better oxygenation.
But the disadvantage has to be the mirror image of VCV's problem.
It's the perfect mirror image. I call it volume volatility. Because you've set the pressure, the tidal volume is now variable. It completely depends on the patient's lung mechanics.
So if their lungs get worse.
If their pulmonary edema gets worse overnight and their compliance drops, that same 20 centimeters of pressure that was giving you 500 milliliters of tidal volume yesterday might only give you 300 milliliters today. And unless you have your low volume alarm set very carefully, the patient can silently hypoventilate.
That's a critical point. Okay, let's talk about another workhorse mode, assist control, or AC. The name itself can be a bit confusing for students.
It can be, but let's break it down. AC means 2 things are happening. The control part means that if the patient does absolutely nothing, if they're deeply sedated, the machine will deliver a controlled set rate of breaths, say 12 per minute.
Okay, that's the backup.
That's the backup. The assist part is what happens if the patient tries to take a breath on their own. The machine detects their effort, their trigger, and it assists them by delivering a full, preset, mandatory breath.
A full one, not just a little help.
The whole enchilada. Every single time, whether you're in volume AC or pressure AC, if the patient asks for a breath, they get the whole machine breath you've programmed in.
So if I've set the volume to 500 milliliters in volume AC, and the patient triggers a breath, they get 500 milliliters.
Yes, every single trigger results in a full 500 milliliter machine breath.
Now this sounds great for resting the respiratory muscles. They just have to make a tiny effort and they get a full breath.
It's excellent for that. But what about the anxious patient? Or the one with a raging metabolic acidosis who has a drive to breathe really fast.
Oh, I see the problem.
That's the danger. Imagine a patient who is in pain and wants to breathe 30 times a minute. In AC mode, they trigger 30 times. The machine gives them 30 full 500 milliliter breaths. That is a massive amount of ventilation.
Hyperventilation.
Severe hyperventilation. They'll blow off all their CO2 and develop a severe respiratory alkalosis. Plus, they might be breathing so fast they don't have enough time to fully exhale. That leads to air trapping, or what we call auto-PEEP.
So to solve that problem of breath stacking and hyperventilation, we have SIMV, synchronized intermittent mandatory ventilation.
Right. SIMV was designed as a sort of hybrid solution. You still set a mandatory rate, let's say 10 breaths per minute. The machine guarantees those 10 breaths will be delivered.
Well, what's the key difference from AC?
The key difference is what happens between those mandatory breaths. In SIMV, the patient is free to breathe spontaneously on their own. And those spontaneous breaths are not full machine breaths. They are just whatever volume the patient can pull on their own power.
And it's synchronized, right?
Yes, that's the S. The ventilator has a window of time. It waits for the patient to make an effort to deliver the mandatory breath, syncing up with them. If no effort comes, it will deliver a time-triggered breath at the end of the window.
It sounds like it would prevent that fighting the ventilator feeling. But you mentioned there's a specific warning about SIMV, especially when it comes to weaning.
This is a very high-yield exam point. For decades, we used SIMV to wean patients off the ventilator. The logic seemed sound. We'd just turn the mandatory rate down from 10 to 8 to 6 and make the patient do more work.
But it doesn't work that way.
The evidence now strongly suggests it may actually delay weaning. The problem is the variable workload. The patient gets a free ride on the big mandatory breath, then has to work really hard for their little spontaneous breath. It seems to confuse the respiratory center and cause diaphragm fatigue. It's often better to just switch to a fully spontaneous mode.
Which brings us perfectly to pressure support ventilation, or PSV. You call this the comfort mode.
It is. PSV is a purely spontaneous mode. There is no set rate. The patient has to trigger every single breath.
So what does the machine do?
The machine simply provides a boost of pressure during their inspiration. Let's say you set a pressure support of 15 centimeters of water. When the patient starts to breathe in, the machine gives them that 15-centimeter push to help them overcome the resistance of the breathing tube and inflate their lungs. It's like power steering for breathing.
He sounds very comfortable for the patient. Now, here's the classic Viva trap. How does the ventilator know when to stop the breath in PSV? It's not set by time, and it's not set by volume.
This question separates the students who really get it from those who just memorize names. PSV is flow cycled.
Flow cycled, explain that.
The ventilator is constantly monitoring the rate of airflow going into the patient. As the lungs fill up, that flow naturally slows down. When the inspiratory flow drops to a certain percentage of its peak, the default is usually 25%, the machine says, okay, inspiration is done, and it cycles off, allowing exhalation.
Flow cycling at 25%.
Flow cycling at 25%. Got it. So what's the big limitation of PSV?
Apnea. It's a spontaneous mode. If the patient stops breathing for any reason, too much sedation, a neurological event, the machine does nothing. It just waits. You would never, ever use pure PSV on a paralyzed or heavily sedated patient without a mandatory backup mode enabled.
Okay, let's quickly distinguish PSV from CPAP, continuous positive airway pressure. They often get confused.
It's a great point to clarify for an exam. Mechanically, P positive and expiratory pressure and CPAP are the same thing. They are both just positive pressure at the end of expiration to keep alveoli open.
So what's the difference? The terminology depends on the context. We use the term PP when it's the baseline pressure we set in a mandatory or assisted ventilation mode like VCV or PCV.
Okay.
We use the term CPAP when we're talking about a purely spontaneous mode where that positive pressure is applied continuously throughout the whole breathing cycle, but there is no extra inspiratory boost or push from the machine.
So PSV gives you an inspiratory push above the baseline PEEP. CPAP is just the elevated baseline pressure itself with no extra help.
Perfectly put. PSV is assist. CPAP is just holding the airways open.
Let's pivot to clinical application, a really critical area. Acute respiratory failure, and what's often called a lung protective strategy. This is all about the ARDS SNET protocol.
Yes, and for the exam, you absolutely must mention the concept of the baby lung.
The baby lung.
In severe ARDS, the disease isn't uniform. You have large parts of the lung that are collapsed or full of fluid and completely unaerated. The only part of the lung that's actually participating in ventilation might be very small, the size of a child's lung.
So it's a functionally small lung inside an adult chest.
Exactly. And if you try to pump normal adult-sized tidal volumes into that small baby lung, you will cause massive overdistension and damage. That's volutrauma.
So the strategy is to use small breaths.
The strategy is low tidal volume. Specifically, the number to remember is 6 milliliters per kilogram of predicted body weight.
Not actual weight. That's a key point.
A critical point. You use a formula based on height because lung size correlates with height, not weight, and you stick to that low volume.
But if you're using such small breaths, what happens to the patient's CO2 level? It must go up.
It does, and we let it. That's the concept of permissive hypercapnia. We will accept a respiratory acidosis, letting the pH drop as low as 7.2 mina, sometimes even a bit lower, in order to save the lung from physical damage. We prioritize protecting the lung over normalizing the blood gas numbers.
Okay, that makes sense. Let's do a rapid-fire comparison round now.
Yeah.
The kind of thing you might draw on a table in your exam answer.
Right.
First up, VCV versus PCV.
BCV. You get a guaranteed volume, but you have unstable variable pressure. It risks barotrauma.
And PCV.
PCV. You get a stable, controlled pressure, but your volume is unstable and variable. It risks hypoventilation. VCV has constant flow. PCV has decelerating flow.
Perfect. Next pair, AC versus SIMV.
AC. Every single patient trigger results in a full, mandatory machine breath. It's great for resting the muscles, but it carries a high risk of hyperventilation and breath stacking if the patient is tachypneic.
SIMV.
SIMV. Only the scheduled mandatory breaths are full machine breaths. In between, the patient takes their own spontaneous breaths. It was thought to be good for weaning, but it may actually fatigue the muscles.
Got it. And finally, PSV versus CPAP.
PSV provides an active inspiratory assist, that pressure boost, and it's flow cycled.
CPAP.
CPAP provides no inspiratory assist. It's just a constant baseline pressure to stent the airways open.
Excellent. We've mentioned trauma a few times. Let's categorize the complications properly under the umbrella term VALI ventilator-associated lung injury.
Yes, for a written answer, you should list these. First, barotrauma. That's gross air leak from high-pressure think pneumothorax. Second, Volutrauma. That's the overdistension of alveoli from using tidal volumes that are too large. This is what the low tidal volume strategy is designed to prevent.
Barotrauma, Volutrauma.
What else? Atelectrauma.
They...
This is the sheer stress injury that happens at the microscopic level from the repetitive opening and closing of unstable alveoli, especially with low PEEP.
And there's a fourth one.
Biotrauma. This is the idea that all that physical stress on the lung tissue causes the release of inflammatory mediators, cytokines, that can then leak into the bloodstream and cause multi-organ failure. The ventilator injury isn't just confined to the lung.
And beyond ballet.
Well, you have patient-ventilator asynchrony, the patient fighting the ventilator, and of course the major hemodynamic complications. All that positive pressure in the chest squeezes the great veins, which decreases venous return to the heart, and that can drop your cardiac output and cause hypotension.
Okay, let's put it all together. Clinical decision-making. I'm going to give you a scenario. You tell me the thought process for choosing a mode. First up, a standard post-op patient just had their gallbladder out. Healthy lungs.
Keep it simple. Start them on VCV or volume AC. You want guaranteed minute ventilation while they're still groggy from anesthesia. Once they're awake and breathing well, you can switch to PSV for a short while, or just put them on a T-piece to see if they're ready for extubation.
Okay, next scenario. A patient with a severe COPD or asthma exacerbation.
The number one problem here is not getting air in, it's getting air out. Their airways are obstructed, so the biggest danger is air trapping or auto-PEEP.
So how do you set the ventilator?
You have to give them a very long time to exhale. So you'd use a low respiratory rate and a short inspiratory time. This creates a low IE ratio, like 1:3, or even 1:4. You are prioritizing expiratory time above all else.
Makes sense. Okay, last one. A neurological patient with a head injury and high intracranial pressure, or ICP.
Here, the absolute priority is strict CO2 control. You cannot let them hypoventilate. An elevated PK2 causes cerebral vessels to dilate, which will spike their ICP and can cause herniation.
So you need a mode that guarantees ventilation?
You need a mode that guarantees minute ventilation. So you'd use something like CMV or volume AC. This is not a patient you want on a spontaneous mode where their ventilation could be erratic.
Great. Let's hit those Viva traps one more time. The classic question. What is the difference between peak pressure and plateau pressure?
This is a must-know. Peak inspiratory pressure, or PIP, is the highest pressure reached during inspiration. It reflects the pressure needed to overcome both resistance and lung elasticity.
And plateau.
To measure plateau pressure, you have to perform an inspiratory hold maneuver. You pause the breath at the end of inspiration for about half a second. This eliminates flow. So the plateau pressure reflects only the elasticity or the stiffness of the lung and chest wall.
So how do you use that clinically?
It's a diagnostic tool. If the peak pressure is high but the plateau is normal, the gap between them is large. That means you have a high resistance problem. Think bronchospasm or a kinked ET2.
And if both are high?
If both peak and plateau are high and the gap between them is small, then you have a compliance problem. The lung itself is stiff. Think ARDS, pulmonary edema, or a tension pneumothorax.
Perfect. Finally, for that written answer, diagrams. How important are they?
They are absolutely critical. A good diagram can be worth 5 marks on its own. You must be able to draw the waveform.
Specifically?
Draw the flow waveform for VCV, that classic square wave. Then draw the decelerating ramp waveform for PCV. And definitely draw the pressure time curve showing the difference between the peak and plateau pressures. It shows the examiner you understand the mechanics visually.
Okay, let's bring it all home. Let's summarize the absolute key take-home points for the exam.
All right, 1. Mechanical ventilation supports. It doesn't cure. Always start with that. 2. Understand the equation of motion. Pressure has to overcome resistance and elasticity.
3. Know your big 3 phase variables for any breath: trigger, limit, and cycle.
4. VCV guarantees volume but risks barotrauma. 5. PCV limits pressure but risks hypoventilation.
6. PSV is for spontaneous breathing, provides an inspiratory boost, and is flow cycled. That's a key Viva point.
7. In ARDS, the strategy is lung protection. That means low tidal volume 6 milliliter per kilogram of predicted body weight and permissive hypercapnia.
8. Always prioritize protecting the lung from injury over normalizing the blood gas numbers.
And maybe a safe answer strategy. When an examiner asks which mode is best, a very good answer is often the mode the clinician and the ICU staff are most familiar with, provided lung protective principles are always respected.
That's a great one. And a final provocative thought for our listeners to mull over.
Well, we've spent all this time talking about modes, VCV, PCV, SIMV, but are we actually moving away from the whole concept of modes? The big textbooks suggest the future is in intelligent, adaptive, closed-loop systems. Things like NAVA, where the ventilator reads the diaphragm's electrical activity, or adaptive support ventilation, where the machine adapts the settings breath by breath based on the patient's mechanics.
So the ventilator starts to think for us.
In a way, yes. But for your exam and for today's practice, you absolutely need to know how to think for the machine.
An excellent point to end on. Thank you. This has been an incredible masterclass.
My pleasure. Good luck in the exam.
Catch you next time on The Deep Dive.